Hello, I'm Stefan Tolan, one of the orthopedic sports surgeons with Steadman Hawkins Clinic of the Carolinas, part of the Greenville Hospital System University Medical Center, and I wanted to talk to you today about subacromial impingement or shoulder bursitis. This is a common syndrome that's noticed mostly in people in their 30s, 40s, and 50s. Usually it does not occur with an injury, happens with repetitive overhead activities, sometimes can be aggravated by a single event where people relate to lifting something wrong or pushing something overhead, and then over a certain amount of time they develop pain in the shoulder with decreased ability to function overhead. Usually there's not an associated loss of motion, usually it's just pain and sometimes with some weakness because of the pain, but not really weakness from a tear in the shoulder. This condition occurs in the area above the rotator cuff. In this model here of a right shoulder, the rotator cuff are these structures coming around the shoulder here, and then this structure here is the acromion or the bone that protects the top of the shoulder, and the clavicle coming here to the front. The subacromial impingement or the bursitis occurs in this area above the rotator cuff and below the acromion, where there's normally a small fluid-filled sac called a bursa. That's there to kind of decrease the friction between the top of the rotator cuff and the acromion bone when the arm's brought overhead. With weakness in these muscles or inflammation in the bursa, the space between the rotator cuff and the acromion can get narrowed, and then that can rub on the bursa, causing the bursa to thicken and produce more fluid. This is an inflammatory process that causes pain and decreases the ability to work overhead. This almost gets caught in a cycle where the more pain, the less you use it, the weaker your rotator cuff gets. The weaker the rotator cuff gets, the higher the head slips up a little bit, and then the worse the impingement is. Usually this can be treated without surgery. 80 to 85% of people can get better with conservative treatment. Usually we'd prescribe anti-inflammatory medications. A lot of times we would also instruct the patient on specific rotator cuff strengthening exercises or place them in physical therapy. The goal of the strengthening exercises is to strengthen the rotator cuff to help diminish and prevent the recurrence of the impingement. If the bursitis is significant, a lot of times an injection with a cortisone will be made, and it'll be placed into the subacromial space with a small shot in the back of the shoulder. It's a very easy procedure to perform. It's not very painful, but it has a pretty dramatic and quick effect by placing the high dose of the medicine in the affected area. It's also a test for us, because if the pain goes away quickly and relieves a majority of the pain, then we know we're working in the correct area and with the correct diagnosis. So the injection is not only a treatment, but it's also a diagnostic tool for us to help us confirm that our diagnosis is correct and that we're treating the appropriate condition. Most people will do well with the injection and the physical therapy exercises. Sometimes the injection's repeated. Usually if one or two injections have been given and the symptoms are not responding, we'd consider other injuries inside the shoulder, such as a biceps injury or a tear in one of the muscles in the rotator cuff. These are all anatomically in the same area, so sometimes it's difficult to tell which is the main cause of the problem. After the conservative treatment has not worked, usually an MRI scan would be obtained. The MRI scan is an imaging study where you just lie on a table and pictures are taken on the inside of the shoulder that can show the rotator cuff, the biceps tendon, and the different structures on the inside to help confirm or to rule out tears in the biceps or the rotator cuff. If no tears are found in the rotator cuff and the subacromial impingement or the bursitis is persisting despite the physical therapy and the injections, we would talk to you at some point about an arthroscopy, which is a minimally invasive outpatient procedure where several small nicks are made in the skin about the shoulder, and a small camera is inserted into the shoulder where we can check all the structures on the inside of the shoulder, check the biceps tendon, check for any kind of tear that may have not been picked up on the MRI scan. But the main purpose of the arthroscopy is to look at this bursa, or the space in between the acromion and the rotator cuff, and we would clean out the thickened part of that bursa to clean out the swelling and the inflammation. And then a lot of times we would smooth the front edge of that bone down with a small burr to give more clearance between the rotator cuff and the bone, so when the arm is brought up, it doesn't impinge or pinch the rotator cuff between the acromion. This is very successful. It works 95% of the time, and it's quick to get over. It's not like rotator cuff repair where there's a lot of healing that has to be done. Usually you just wear a sling for a week or so, and then physical therapy is started to get the motion back in the shoulder. And then it's still important after you've recovered to continue your strengthening exercises with your rotator cuff at home to keep it from coming back. Usually by 2 to 3 weeks, most of the motion is returned to the shoulder, and by 6 weeks you can get back to activities such as golf and tennis.